Hey, Corinne, welcome to Dear Menopause.
Thank you for having me. I'm so excited for this conversation.
Yeah, I am too. I think for our audience, particularly given my audience is very Australian, New Zealand based, perhaps not familiar with who you are and why I have you here today, would you like to give yourself a little bit of an intro?
Sure thing. My name is Dr. Corinne Menn, and I'm a board certified OBGYN and a Menopause Society certified practitioner. And I've been practicing for, oh goodness, almost 23, 24 years now. And in recent years have really tailored my practice to the treatment of the menopausal woman, as well as breast cancer survivorship issues. And the important thing to know about me is that I have the professional expertise, but I also have the personal experience of being a long-term breast cancer survivor. So really that's how I found my passion of taking care of women in menopause and with breast cancer. Because when I was 28 years old, I was a second year OBGYN resident. I was diagnosed with stage 2A ER/PR positive, HER2 negative breast cancer 6 weeks after my mom suddenly died of ovarian cancer. Many years later, found out I do carry the BRCA2 gene mutation. Because no one helped me with my menopause symptoms and the collateral damage beyond menopause symptoms of breast cancer treatment, as well as just seeing that in the US at least, and I know certainly throughout the world, that OBGYNs are not trained in menopause care in general, much less in a breast cancer survivor, and they're not really trained at all in sexual health and addressing those issues, that I needed to really up my game just to take care of the average woman, and then go one step further and really take care of the menopausal woman who's also either a breast cancer survivor or who is at high risk. So that's really what I'm all about these days. And I only practice by telehealth now, via Alloy, which is a menopause platform in the US, but also in a small private practice. And really have just gotten excited about doing a lot of social media, patient education, because I'm just really passionate about, education. So
Yeah, and I'm so grateful because I discovered you through your social media platform and presence, obviously, and through different connections, that we have in common. Um, I really want to talk to you today, and I think it will be really beneficial for my listeners to hear a little bit about your own experience with your breast cancer journey and your menopause journey in particular as a result of, I know a little bit about your story and you kind of went in and out of menopause a couple of times for various reasons. I think it'd be great for people to hear that side of the story because you were so young when you were diagnosed as well. And then I'm really keen to dive into talking about the gap in care for women that are surgically or medically induced menopause, and then going into the treatment for, or that's available for women to manage their symptoms, how that is managed, how it's changing, and what we can do to kind of perhaps create a little bit more change more quickly. So let's start with your story around, your what you're happy to share around your menopause kind of experience.
sure, I'm super open about my breast cancer story and my menopause. So basically I was 28 and I again, stage 2A breast cancer, elected to have a bilateral mastectomy with reconstruction. And then I did, prior to starting chemotherapy, which I did 6 months of chemo, I did save some eggs to protect for fertility preservation. Never wound up needing those. We'll get to that because I was able to get pregnant on my own. But I bring that because the first kind of interesting point is they used tamoxifen to stimulate my ovaries, because tamoxifen is a cousin of Clomid. So I got, lots of multiple, eggs, ovulation, and tamoxifen makes your estrogen levels go up. So just wanted to put that out.
And that's
So
only if you're premenopausal, is that right?
you're premenopausal, yeah. If you're premenopausal, so save some eggs, delve in, did 6 months of chemo, and within, a couple of months, my ovaries temporarily shut down. So from the chemotoxic effects on my ovarian function. But because I was very young, I did eventually, when chemo ended, I was able to regain, ovarian function. So that was menopause hit number one. So it was a temporary chemical menopause from chemotherapy. And looking back, I think that, yes, there was lots of hard things about having chemo, but looking back, I think a lot of my symptoms that I struggled with during chemo like insomnia, increase in anxiety, a lot of symptoms. I think it was really just this kind of profound new sudden menopause at 28. So that was pretty rough. Finished chemo, came out of that and went on tamoxifen. A few months later, my periods did come back. And so I did handle tamoxifen okay at first. Then they're like, well, let's add some Lupron. So they shut down my ovaries. And I was like, okay, great. I didn't know. Well, that was, menopause number 2 from having, ovarian suppression with the tamoxifen. So I did that for a little bit of time. Then I stopped that, and in conjunction with my oncologist, decided to pursue a pregnancy. So pause my adjuvant endocrine therapy so I could get pregnant, which is something that is now like pretty widely supported in the oncology community. At the time, remember, this was, about 23 years ago.
Yeah.
I was lucky. I was in New York City, and I had some really like cutting edge doctors who were like really looking at this. And we had data all the way back then that women could probably pause therapy, endocrine therapy to get pregnant. So luckily I had access to that information. So had came off my tamoxifen, got pregnant very easily on my own. I didn't need those little eggs that I saved, and had a successful baby, pregnancy, and I have a 19-year-old daughter now. And as soon as I delivered her, I went right back on my tamoxifen. They put me back on Lupron again, and I like only lasted a few months. I was like, yeah, I'm not doing this anymore. I can't do the Lupron. It was really rough. So I just kind
So
of.
do you mind if I interrupt you there for
Yeah,
1 second? Lupron isn't a drug that I'm familiar with. So what does Lupron do?
So Lupron's like Zoladex. It's just an injection for ovarian suppression. So when women are premenopausal and we want to make them temporarily menopausal and quiet their ovaries down, and we often do it in younger patients with a more aggressive breast cancer when we want to give them an aromatase inhibitor. Aromatase inhibitors only work if you're menopausal. So you can either remove the ovaries surgically, or we give you a shot. So that's what Lupron did for me. And it was pretty, and it was really hard having that kind of chemical menopause hit me again. Trying to be a new mom with a new baby and a new young doctor. So I kind of, my oncologist said, okay, just stay on tamoxifen. And so I had regular menstrual periods and, plenty high levels of estrogen. Just had, 9 months of high levels of estrogen, during my pregnancy. And for me, and I know not everybody tolerates tamoxifen, but for me, I really didn't have a problem with tamoxifen. And I did that for, a number of years. And then, I decided, so I alluded to that, right before my diagnosis, my mom had died suddenly of ovarian cancer. It's a tragic story. It's for another podcast, but, we had no family history. We did not know we carried any mutation. And so it never sat right with me. I'm like, wow, I'm 28 with breast cancer, and my mom was 54 when she died. And my initial genetic testing was all normal, negative. And I was like, really? Did you do the right test? Well, they didn't. They didn't. I'll tell you about that. But at that point, I was like, okay, my baby was a year old. I was like, you know what? I think I want to stay on my tamoxifen. We chose to grow our family through adoption. And so we adopted a baby girl from Guatemala, and she is now 17. And she just texted me. She got a college acceptance. So we're so excited.
Oh, so exciting.
Yeah, so like, wow, like, I never would have thought that I'd ever be here. I thought that honestly, breast cancer would have gotten me a long time ago. I really just wanted to get through, I don't know, just maybe getting my kids to age 10. And now the fact that they're almost, in their late teens, early 20s, so blessed. But anyway, so we decided like, we're not going to have any more babies ourselves. So we're going to adopt. So I'm like, I want those ovaries out. And this is a really interesting point, because at the time, I think it was 33 or 34. And there, no oncologist, no one was saying, Corinne, we need to shut your ovaries down. They weren't saying that. I was early stage breast cancer. I was doing very well on tamoxifen. I had lots of estrogen, right? Having normal menstrual cycles. They're like, you don't have to do this. You don't have to remove your ovaries. It wasn't a treatment for my breast cancer. It was a treatment because I thought that something was just not right. I was like, I want those ovaries out. I'm not trusting this genetic testing. And I'm glad I didn't trust it, because lo and behold, a number of years later, I realized in 2013 that the standard kind of panel that they did, looking at the BRCA gene, did not include the large rearrangement of the gene called the BART sequence. And that's where my mutation was. So in 2013, I demanded to get retested, not even panel tested, which we do now, where we're looking at more than the BRCA gene. It was just a repeat of the BRCA test. And lo and behold, yes, I carry the BRCA2 mutation. So I listened to my gut. There was something wrong with my genes.
Yeah.
So that's why I had my ovaries removed. But what that did was overnight put me into surgical menopause, which was something that couldn't even compare to what I dealt with the temporary kind of chemotoxic menopause or the temporary menopause from Lupron. Having that surgical removal of my ovaries was like a whole new level of really suffering, right? So, and so I had no ovaries and surgically menopausal, and I stayed on tamoxifen. And that's when the tamoxifen was harder to manage now because it was now being given in a different environment, right? And I think that was probably my lowest point in my symptoms. And that's when I decided to go to the North American Menopause Society, now called the Menopause Society, and get certified and really understand, because I was like, God, if my patients are dealing with this, I'm like, I've got to learn to help them. But I still didn't know really how to help myself as a breast cancer survivor. I was like, I can help other people, but I'm just going to have to suffer. I'm just lucky I'm alive, right?
Yeah.
And so that's where I was there. And then it took many years for me to, really learn the nuances of the breast cancer, survivor and how to manage them.
Yeah, there's a couple of things I'd like to kind of pick up from that you mentioned. The first one is going back to when you were in your initial chemically induced menopause. You mentioned that you had some menopausal type symptoms, or you now recognize them as menopausal type symptoms. One of the things that I have noticed, and I'd love to get your thoughts on this, is there seems to be a quickness from an oncologist perspective to dismiss a lot of the symptoms that women are experiencing and just fobbing them off as chemo symptoms. Yeah. And I even had this happen to me about 2 months ago when I was speaking on a panel. Actually, it was World Menopause Day, and I was speaking on a panel speaking from a lived experience perspective, and there was an esteemed doctor on the panel, and she had to throw the comment in right at the end, well, Sonia, you had gone through chemo. They were potentially just all chemo symptoms. And I wonder how often or how easy is it to actually distinguish between what is chemo symptoms? And let's be honest, chemo is awful and does come with its own, symptoms. But when you're also experiencing that induced menopause state, how do we ask our oncologists to see the difference between those two states?
Yeah, well, listen, if you think OBGYNs don't know anything about menopause, and most of them don't, because I'm telling you, we're not trained with, there's not much, curriculum in the OBGYN residency in menopause. Oncologists have no education in menopause. They think of it like the general public thinks of it as only hot flashes and only night sweats. So if you're not having those things, then they don't think of it as menopause. But, I know that there's over 30 symptoms probably with menopause, including, joint pain, dry skin, mood changes, anxiety, insomnia, heart palpitations, sexual side effects, bladder problems. I mean, the list goes on, right? And so do we have a good way to say what's chemo and what's menopause? No, but I think it wouldn't really be that hard to educate oncologists and OBGYNs to just kind of recognize that two things can exist at the same time and they both worsen each other, right? So, some of the side effects of chemo are going to make it really harder for you to cope with hot flashes or insomnia. And the insomnia and the hot flashes and the mood changes are going to make it harder for you to cope with chemo. So we should take them both seriously and not just write them off as, oh, it's just chemo brain, right? And I think that a lot of women who then stay in menopause, because obviously depending on your age and depending on your treatment plan, it may not be temporary, right? And so I see a lot of women who then, all right, the chemo's done, it's 6 months, it's a year, it's 2 years, and now they're in permanent menopause for whatever reason. And they're convinced that it's chemo brain is why they have some cognitive changes and brain fog. And I am not discounting chemo brain. I know that there's data and science showing it's a real thing. I believe it. But please, please do not ignore the elephant in the room that we know there's huge cognitive changes, and memory and brain fog and all this stuff, and the insomnia and what that does. And we need to recognize that and treat it and understand it. And I think oncologists are living in a silo, and they're not looking at the bigger picture of the collateral damage that's happening out there. And I don't fault them. They're working so hard and they're so busy, and medical practices don't really give them the time to really look holistically at patients, and neither in the OBGYN world does it. And I know that their perspective is they just want to cure us and keep us cancer free. And I love that. And I love my oncologists, but I think we just have to think more holistically.
Yeah, I agree. And I think, I feel quite strongly that there needs to be more of an ethical responsibility from the surgeons or the oncologists that, at the end of the day are responsible in some ways for
100%.
putting women into these forced menopause states.
Oh, if you break it, you fix it. Like, that's like, there's a saying, like, first do no harm.
Yeah.
And so, and I'll give a perfect example of, I see these patients all the time who are either new to their adjuvant endocrine therapy, or they've been on it for a few years. So they're on an aromatase inhibitor, or they're on tamoxifen, and they may be really struggling. And again, not everybody struggles. There's all, we understand there's, lots of different ways that people respond to this. But I asked them, I'm like, did anybody actually give you informed consent on this adjuvant endocrine therapy and explain to you the risks, the benefits for you individually? And I think that if women would understand the benefit, the true benefit, as well as the true risks, they could better make an informed decision. But what's told to them is you have a 50% decreased risk of a breast cancer recurrence if you use this adjuvant endocrine therapy. And you probably see this more and more. There's more and more women who are being told 10 years aromatase inhibitor and ovarian suppression, right? So what I like to say is, like, extreme adjuvant endocrine therapy. And for some women, yes, that risk reduction is worth it because they have a higher disease burden, they have a higher risk of recurrence, but they should be fully informed of what that risk reduction is. So what I'm seeing is, like, say, a stage 1A, low grade, moderate grade, node negative patients being kind of basically railroaded into very extreme adjuvant endocrine therapy, being told it's a 50% reduction. So then I said, well, did they tell you what your baseline risk is? Well, no. They say, no, I don't know that. And so then we look it up, we look at their oncotype score or whatever, information their oncologist said, and it said, oh, it's actually a 6% risk of recurrence. And if I do this, it cuts it in half to 3%. And then I say to them, okay, so it's a 3, so fine. All right. So there's a risk reduction there. But then I say to them, did they explain to you that when they give you those numbers, they're talking about adjuvant endocrine therapy in general, and the nuances then between ovarian suppression and an aromatase inhibitor versus tamoxifen, you're talking about single digit differences, right? So, when you put it in that perspective, and I says, you've already done it for 2 or 3 years or 4 years, like, there is this law of diminishing returns over time. And yes, maybe you would get the maximal benefit at, say, 10 years with the most extreme adjuvant endocrine therapy, but at what cost?
Yeah.
And did anybody explain to you that maybe you're getting a couple percentage benefits? And they say no, they're not. And so to me, I don't even think, not only are they not being talked about how to deal with their menopausal symptoms, I don't think they're actually being informed of the benefits as well as the risks and what the true reduction is. And it also works on the other end of women who have very high risk for recurrence disease or a high disease burden. Those women, sometimes they want to abandon their therapy because they don't understand the risk reduction. And so I said, listen, let's go through it. For you, wow, you have a 30% risk and it's lowering it to 15%. So let's work together to find ways for you to stay on it, So I think I see patients on both spectrums, people who are probably can maybe come off it or change it up and make it more manageable, and they're not being informed of what they can do there. And on the other hand, women just being so miserable that they give up on it because no one's addressing their symptoms. And so I feel like we're failing both groups of those women.
Mm.
I don't think we do this to men. If you cut a man's testicles off and you didn't address their testosterone and you didn't address their sexual function and what they feel like it would be considered just cruel, unusual. And guess what? It doesn't happen. It doesn't happen in the male world, but it's happening to women because there's an acceptable level of women suffering in the name of curing their breast cancer. And there's an acceptable level of suffering at menopause. It's like, just deal with it. And so the people who are most vulnerable, which would be the cancer survivors, the women with premature menopause, the women with surgical menopause, the level of suffering is, the acceptable level of suffering is really, really high. And it's cruel.
It is cruel. Yeah. Yeah. Where do you think that acceptance of suffering comes from?
Oh, I mean, the devaluing of women. This is misogyny at its finest, I think, and, I think that I don't think individual physicians are misogynist. I'm certainly not saying that, but I think there's a cultural norm that, there's a rite of passage to menopause for the average woman, that they should just suck it up and deal with it. I think that when you're talking about cancer, and I always tell patients, whenever you're getting advice from doctors, think about the lens that doctor is looking at you from, right? So the oncologist wants to, cure your cancer from
Save your life.
medical.
Yeah.
The breast surgeon wants to cut it out and ship you off. The plastic surgeon wants to make you look pretty at all costs, even if it's like too many surgeries for you personally, or even if it's like you don't want even reconstruction, you just want to go flat. And some plastic surgeons be like, why would you do that? I can make you beautiful, right? So everyone has their lens. The OBGYN has their lens. And, frankly, all of these lenses are clouded by fear and misinformation. So the OBGYN, the minute they hear you had breast cancer, it's like they glaze over. They're like, oh, okay, well, I don't really know what to do with you. Like, you're high risk. I can't touch you. I can't give you anything. Like, I can't talk about hormones with you, right? The oncologist is like, their lens is like, I don't know anything about sex and hot flashes. Like, please be lucky you're alive. Why would you care about that? And so, I always tell women, don't blame the doctor. They're kind of a victim of the medical training and the system, and understand that their lens is kind of shaping the advice they give you. And they're only hearing the literature from their little world. Like, we're not all getting together. Like, the menopause doctors aren't getting together with the oncologists and the breast surgeons. We're all going to our own conferences and our little silos, and the woman is left in the middle,
Yeah. Yeah. I think that's a really concise description of exactly what is going on.
And I think that it takes a lot of work on a patient's part, and it's a lot of onus on you as a survivor. And it sucks because it's like, God, how much do we have to ask of these women to be medical experts in addition to being survivors and just living their lives and taking care of their families and going to a job? But you know what? Your life is worth it. And you have to educate yourself, and you have to be pushy. You have to be, and I think most doctors are actually caring people, and they're smart people. And if you advocate for yourself, and it may take a couple of doctors, you may have to jump around a little bit, you will find help eventually, but it's hard.
Yeah, absolutely is. One of the other things I'd like to start diving into with you, we mentioned right up the front, is what for these women that are really struggling and having a poor quality of life, often as a result of being in this menopausal state. What treatment options are available? And, I really want to talk about hormone therapy here as well.
Absolutely. So I think when I talk to patients about what we're going to do, I think we always have to put it first in, like, where are you in your treatment course, and explain to them that the way we help you is going to evolve as your survivorship evolves, right? And so I think on the very front end, when they're going through therapy and they've made their decision on their treatment plan, which is unique for each individual, number one, they should be fully informed, as I alluded to, because I think sometimes their treatment can be tweaked to help, make it more tolerable and really more humane and holistic. But if you're in the middle of treatment with something that is going to be, with some type of adjuvant endocrine therapy, and there's absolutely no discussion of systemic hormones, we have non-hormonal ways that we can help your menopause symptoms. They're underutilized, and they're often not offered until patients come in crying and begging for help. And even then, there's often not a lot of nuances. And so I would direct people, when you're looking for non-hormonal ways to help with systemic menopausal symptoms, that would be hot flushes, night sweats, insomnia, I think you can look to the Menopause Society non-hormonal position statement that they published in 2023. And it's beautiful because it really is an evidence-based look with everything laid out very clearly of all the different medications that are off-label, so SSRIs, SNRIs, the new medication Veoza, oxybutynin and gabapentin. Those are the big medication ones that we can do. And then also CBT and lifestyle things. And so I think it's really important for women to be aggressively offered those things. And at all stages, women should be aggressively offered vaginal hormones because we have so much safety data. There is no reason for a breast cancer survivor at any point in her treatment, even if she's on an aromatase inhibitor, she should be able to use vaginal hormones. And we've got lots of different ways that we can, give that to them. And we've got consensus statements on that. And we have a lot of data there. So that's kind of the easier thing to address. And even that is not well addressed in patients.
No.
Then the next stage would be, okay, you've finished your treatment, whether you're estrogen receptor positive, estrogen receptor negative, whatever it is, you've moved on. And now you're looking at, well, what's next? Okay. That and if you're then at that point dealing with a lot of menopausal symptoms, or because I think women should have true autonomy, even if your menopausal symptoms at this point aren't severe, but you want to have a smart, intelligent conversation about the risks and benefits of hormone therapy. And hey, can I get some of these benefits that I've heard about? I think you are owed the conversation, and it should not be a blanket no. And I think that we always can talk to patients about non-hormonal ways to manage their symptoms, as I alluded to. We should always talk about use of vaginal hormones for local non-systemic treatment of their genitourinary syndrome and menopause symptoms, and lifestyle. These things are so important, but it is unreasonable to categorically deny women access to what the scientific literature shows about the use of low dose FDA approved in the US, or kind of approved standard hormone therapy. And what does it mean for a breast cancer survivor? Because actually we have data. We do not have perfect data. We do not have data that is consistent across the board, but we actually have data. And so to say, oh no, it's totally unsafe and there's no data is actually not, it's not true. And women deserve more than that. And also women, breast cancer survivors know this, each of our cancers are different. So yours is different than mine. ER positive is different than ER negative. And then even within those categories, there's lots of nuances and different. So to kind of say that all women who have had any type of breast cancer, any stage, any receptor status, categorically are not allowed to even have a discussion about the use of very low dose hormone therapy is absurd. It's absurd.
And we were talking before we started recording. One of the things I wanted to talk to you about was, I'm speaking from an Australian perspective, and I personally was estrogen, progesterone positive, HER negative. And I was 47 when I had my chemo and was diagnosed. So I did go immediately into menopause, medically induced, obviously, but my menopause was permanent because given my age and proximity to my natural menopause stage. I have been categorically denied, point blank, won't even enter the conversation for 6 years, any access to hormone therapy until recently. And, that came off the back of me doing my own research, being privileged enough to be in the position to sit down and have conversations with the likes of yourself and, many other experts in this area. weighing up my own risk versus benefit, and then researching until I found a GP that was comfortable enough to prescribe me some hormone therapy. And that has only been in the last 4 weeks that I have been able to start doing that. Now, when I look at the most recent practitioner toolkit that was published here in Australia about a month ago, we're recording this in mid-December. It was literally published maybe 1 month, 2 months ago. And if you look at that, it's got these beautiful flowcharts on it of how to help GPs decide so our general practitioners decide how to treat a woman. Under contraindications, just point blank contraindications, it says estrogen dependent cancer. So there's a couple of things I want to talk about there. One is the use of that language, estrogen dependent cancer, because one thing I have come to learn, and I think it's my biggest learning for this year, is that my estrogen positive cancer does not mean that estrogen caused my cancer.
That's true. Yeah, and I think that, listen, listen, estrogen positive breast cancer. We have now decades of data showing that, yes, blocking that estrogen receptor or, temporarily suppressing estrogen levels, does help treat that breast cancer. And that's because the estrogen receptor, when stimulated by estrogen, can help send signals to the cell telling it to grow, right? Because let's just kind of talk about a normal breast cell. And I think this really helps patients, I think, understand what we're talking about here. Estrogen as a hormone in a normal menstrual cycle, the first half of your menstrual cycle, your estrogen levels rise. And the job of that in your breast is to start to stimulate, breast glands and breast ducts to, hey, get prepared because she's going to have sex maybe, and she may get pregnant, and you're going to have to be prepping for a baby, right? So in a very simplistic form, the estrogen is rising, your little breast cells are going to grow and kind of get ready. And then progesterone comes along and says, let's get these breast glands and ducts a little bit organized. We can't have unchecked growth. And progesterone is part of this, beautiful, growth and organization. And then if you're not pregnant, all the hormone levels drop and boom, the whole cycle starts over again. And that's because there's receptors on your breast cells in a normal, healthy breast cell, estrogen receptors and progesterone receptors, okay? So what's happened in the world is that when people are diagnosed with estrogen receptor positive breast cancer, because normal women don't talk about estrogen receptors, right? That's not common lingo. So then they're, oh my God, I have estrogen receptor positive breast cancer. So that must mean that estrogen caused me to get breast cancer and caused this type of breast cancer. No, it didn't cause it, okay? It just means that your breast cancer, and again, why people get cancer is a much more complex, above my pay grade conversation, but your breast cancer cells have retained an estrogen receptor. So yes, they are estrogen receptor positive. They haven't lost those receptors. And one of the benefits of having estrogen receptor breast cancer is that we have all these tools and we can manipulate that receptor and do things so that we can stop any circulating levels of estrogen in your body from binding to the receptor on those breast cancer cells and telling it to grow. Okay. So from a very simplistic standpoint, I think it's just important for women to know all breast cells, healthy breast cells, have an estrogen receptor. Sometimes if you have a breast cancer that develops, it is a breast cancer that has kept those receptors. And women who have estrogen receptor negative breast cancer, those cells have changed so much. They look very different than a normal breast cell. And in fact, so different that they don't even have estrogen receptors on it. So we can't manipulate that cell in any way, okay? And, women who are premenopausal, who have lots of estrogen in their bodies, they get estrogen receptor negative breast cancer and they get estrogen receptor positive breast cancer. Same thing with postmenopausal women. So these cancers develop in both a high estrogen state and a low estrogen state, right? And we don't know exactly who gets what and why. Some of it's genetics, lots of things, right? But it doesn't mean that estrogen caused your breast cancer. And I think it's really important because I think what's happened is women now fear something that their own bodies for years have made. And where I find the conversation get really, really interesting in whether women can consider even a discussion of HRT after cancer is that it's much celebrated these days. And at the last year's San Antonio Breast Cancer Conference, which is the big, US breast cancer research symposium, it's happening right now, actually, in San Antonio. They released the positive trial. So the positive trial was looking at, could women who have ER positive breast cancer take a break from their tamoxifen or aromatase inhibitors, take a break, get pregnant, take 2 years, up to 2 years off of all therapy, get pregnant, and even use assistive reproductive technology. So use whatever they needed to help get them pregnant, high hormones, 9 months of super high hormones, and then go back on whatever tamoxifen aromatase inhibitor and carry on. And I was looking at, all right, well, did they have a higher risk of recurrence and a higher risk of death? And the answer is no, right? And so, obviously it's still an individual decision, and they're still going to look at long-term risks and stuff. But I can tell you that data was there even when I got pregnant, because 23 years ago. So there was data in the literature, but this positive trial was, a formal trial that looked at this. And so it gives us a more solid answer, right? And so it seems like it's not that controversial anymore to tell a woman, like, sure, you can take a break even from in the middle of treatment, take a break, let your estrogen levels be sky high. I mean, I'm talking crazy high, right? But God forbid we let someone who has early stage, well-treated breast cancer, it's behind them, they're really suffering, and they want to have a conversation about using, like I'd say, a teardrop of transdermal estradiol and a touch of low-dose progesterone if they have a uterus still. And it is like, no, absolutely not. And I'm like, what? It makes me so angry. Are we worth it? Are we only here to have babies? But, once we're menopausal, it doesn't matter. Like, that suffering and what we're dealing with doesn't matter. It seems like very strange to me that that's somehow okay, but we can't talk about this,
Yeah,
You can tell I'm emotional about it.
And that's why I wanted to have this conversation with you, because you sit in this really unique position of having the lived experience, and also, treating women that come through your clinic and through your telehealth. But you also have such an in-depth understanding of the research and the studies that have been done behind it. And I feel very strongly, and I believe that, like you, that the tides are turning, that it's time to start having these conversations. I mean, it's well overdue time to start having these conversations and having more public awareness around the nuances that do mean that it cannot be, or it should not be, a blanket no.
No, and some other examples for our triple negative survivor sisters out there. Okay. I have a dear friend and a patient of mine who had triple negative breast cancer. She, had her surgery, her chemotherapy. She went on to have a successful pregnancy, delivered twin girls. They're doing beautifully. And, she wasn't on any adjuvant endocrine therapy because she's triple negative, right? Mm-hmm. And she had normal menstrual cycles and very high levels of estrogen, obviously, for many number of years. And around her, I don't know, maybe early 40s at this point now, she was probably 40. She carries the BRCA1 gene, and she decided to remove her ovaries to lower her risk of ovarian cancer. At no point in time was ovarian suppression or lowering her estrogen levels ever a part of her treatment plan. But the minute she got her ovaries out, everybody was afraid to give her HRT because she had breast cancer, right? But she had one triple negative breast cancer, who she's now prematurely surgically in menopause, which you and I both know has tremendous health risk of increased cardiovascular disease, dementia, hip fractures, depression. The list goes on. I mean, it's actually really significant what happens with premature surgical, menopause. And it took a lot of pushing and working for her to get some damn HRT. And it's absurd. She is now on it, and it's a huge game changer, right? And so that's an example. The other example I have is I have patients who have DCIS who had mastectomies, for God's sakes.
Mm-hmm.
And no, absolutely not. We can't talk about HRT. I'm like, really? You know, like we're scientists, we're doctors. Really, you can't logically think this through. You don't manage patients with blanket statements. It's absurd.
Yeah. One of the last areas I wanted to touch on with you, and thank you for going into, so much depth on that and giving us those examples, because I think when we can, it's why I love doing this podcast so much, is when we can really hear living examples and lived experience of, and then you can really see the almost ridiculousness of those blanket contraindications. But I wanted to ask you around, so HRT has changed in its formulation a lot. Like if we go back to when the Women's Health Initiative was done, that the studies were done on an old formulation of HRT to which we use today. There's a infographic that gets shared a lot, and particularly here in Australia, I would imagine also in the UK, it's produced by the Women's Health Concern, which is an arm of the British Menopausal Society, the BMS. And it's a comparison of lifestyle risk factors versus HRT. Now, it was produced in November 2015. So help me out here, because I'm a little vague on, or I just don't have the knowledge around dates and when hormone therapy kind of changed from being that old formulation to what we now use with the microdosed progesterone and the gel HRT, or the versus, your internally taken HRT. Do we have comprehensive data on breast cancer risk for women that are using the newer body identical HRT?
Unfortunately, we don't. And I think it's because we have some data, and I'll tell you what we have. Unfortunately, the Women's Health Initiative in the United States caused so many long-lasting problems with research in menopause, because once they released their report, which caused havoc around, well, certainly in the US and around the world, and women went off their HRT overnight, there was a lot of, people were not interested in studying more, about it. But even the Women's Health Initiative, which is often much maligned, but I tell patients, no, don't throw the baby out with the bathwater. We learned a whole lot. And there's a lot of good points in the Women's Health Initiative that unfortunately the primary investigators to this day refuse to, celebrate. So let's just remember, and I don't want to malign the old hormone therapy, but I also want to talk about what has changed. So in the health initiative, WHI, they used conjugated equine estrogen in Premarin, right? So in the conjugated equine estrogen arm in women who did not have a uterus, they had a 30% decreased risk of breast cancer. 30% decrease, okay? They had a almost 40% decreased chance of dying of breast cancer and a 30% decreased risk of ever getting breast cancer. And that holds true even, decades later at the 20-year follow-up, right? And then in the other arm, they used conjugated equine estrogen, again, but in oral, with a synthetic progestin. And the reason why the study was halted was because they saw a slight increased risk in the diagnosis, but not in mortality, of breast cancer. But unfortunately, even that doesn't hold water. And that message is what caused everybody to panic, right? But even if you believe their numbers, which I'll explain why you really shouldn't, but even if you believe those numbers, it was one additional case for every 1,000 women taking it. And it was just an additional case of being diagnosed, never an additional case of a woman dying of it. And it was on that basis alone that the rates of HRT dropped by 75%. And I think that had a huge impact then on what happened in the breast cancer survivor world, where then it became even more taboo to consider HRT after estrogen receptor positive breast cancer. So it was like a real perfect storm. But we shouldn't completely malign that conjugated equine estrogen, because that conjugated equine estrogen given orally has never shown, given alone, has never shown an increased risk of breast cancer. In fact, it just told you a decreased risk. What has evolved since then is, a trend, which is a good trend, I think, to bioidentical, but FDA approved or, kind of government approved and regulated and well-studied, bioidentical options. And we have many of them. So we have real estradiol. So, I mean, it's exactly chemically what looks like your own estradiol in your body is, and we have it in gel, so transdermal forms, gels, sprays, and patches. We also have it in oral form. And so at the Menopause Society last year in the US, they did present an article that looked at formulation and breast cancer risk, and they showed that estrogen alone, conjugated equine estrogen, no increased risk. Estradiol alone, no increased risk. Estradiol with a progestin, they used the data from the WHI showing this tiny increased risk. And they said, and then data if it was progesterone, so bioidentical progesterone, no increased risk, so either neutral or maybe slightly beneficial. Now, it's not the same level of data comparing those bioidenticals that we had, like the numbers in the WHI, so smaller numbers, but the trend is that it's at least as safe, if not better. But I should never knock conjugated equine estrogen, because let's face it, all of the good data in terms of showing osteoporosis prevention, lower risk of dementia when women started within 10 years, lower cardiovascular risk when women started the first 10 years, that data all comes from oral conjugated equine estrogen. Let's not forget that, right? So let's not totally misalign it. And the reason why I bring it up is because for the breast cancer survivor, I want you all to know, and I don't know if you guys have this available in Australia, but in the US, we have something called DuoV, which is a combination of conjugated equine estrogen paired with basodoxifene, okay? So it's a very unique HRT option. It's an oral option. But why I want your listeners to know about it, and do you guys have this in Australia?
I haven't heard of it. Doesn't mean we don't have it, but it's not something I'm familiar with, no.
So this is just very important. So out of the WHI, there was all these fears that the progestin was maybe the culprit in causing this increase. So the drug companies were like, well, what could we do here? What could we pair, conjugated equine estrogen with? And so, researchers and these amazing doctors who helped develop this actually spoke at the menopause conference this past fall, kind of discussing this medication called basodoxifene. So basodoxifene sounds similar to tamoxifen, doesn't it? It's because it's kind of cousin. And it basically, what they were trying to find is what can we give with estrogen that would protect the uterine lining, right? Because that's why we give progesterone, so that you don't have thickened uterine lining and uterine cancer and bleeding. So what can we give that could protect the uterine lining, but also protect the breasts from any extra stimulation, right? So they looked and they said, well, we know tamoxifen has these selective estrogen receptor properties in different tissues. So let's see if we could find something similar to that, right? So they found this medication. It's called basodoxifene. It has very, very strong, powerful anti-receptor effect in the breast. It actually degrades the estrogen receptor in the breast so that it's like not even functional. And it does the same thing in the uterus. So you don't bleed. You have no uterine lining stimulation. You have no increased risk of uterine cancer. It's positive on brain, on the bone, on skin. It's not causing any anti-estrogen effects there, but it's blocking, or I should say degrading, the estrogen receptors in the breast. And I have to say, it was actually very profound to see the slides of showing what breast, what the slide showed, what it looks like in the breast tissue, and how powerful and anti-proliferative basodoxifene is when given with conjugated equine estrogen. So DuoV is an oral one-size-fits-all medication. So it's basically 0.0625 of CEE, so similar to about 1 milligram of bioidentical estradiol, and paired with basodoxifene. So it's not being paired with a progestin. There is no progestin or progesterone. It's this unique thing. So this is a super interesting option for people who have intact breasts, who are ER positive breast cancer patients, because basodoxifene on its own, I think in Europe, they've looked to approve it as a cancer treatment. So basodoxifene, everyone has to think of it as almost like a superpower tamoxifen, right? So, but in the US market, Bayer decided, like, we're not going to pursue that FDA label, right? Even though we know it's a powerful cancer drug. So it's a very interesting thing for people to understand that you might be able to have your cake and eat it too. Treat your menopause symptoms, protect your bones, protect your brain, and also maybe have this powerful effect on breast. So that's one interesting option that I think could be very promising. And yesterday at the San Antonio Breast Cancer Conference, there was data presented and a lot of discussion about this. And my oncology doctor friend and I are gonna, we're gonna be doing an Instagram live where we're gonna talk through the slides and the presentation. So people can stay tuned for that. And then I will say the other option is what you kind of alluded to is, generally in my practice, bioidentical, but regulated, not specially compounded or pellets or anything like that, but
Yeah.
properly approved bioidentical in a transdermal patch, comes in lots of doses, low to high. We can, treat patients based on what their symptoms are by minimizing side effects. And we pair it with a bioidentical progesterone, because bioidentical progesterone has not shown any negative impact on breast tissue and does not also have any negative impact on cardiovascular markers, clotting factors, anything like that. So for my average menopausal patient, I love that. I think DuoV that I mentioned is also another great option. And so I think both of those options are the options that when I am talking about it with someone who's had breast cancer, those are two options that I talk to them about. And when I talk to them about using HRT after breast cancer, we talk about it in a holistic way. What are your symptoms? What is your pathology? What does your oncology team tell you? Let's talk about, your medical situation. And then we talk about what the data shows. Okay. And then these appointments take a long time. And so this is why it's hard for the average oncologist or OBGYN to do it. But I think it's really, really important that women then are able to know that there is published literature. And, this article is the beauty of it all. It's called Hormone Replacement Therapy After Breast Cancer. It is time. It was published in the Cancer Journal in May of 2022 by Avram Blooming. And he did a beautiful literature review with these lovely tables. This one is a summary of 21 studies that have been published between the years of 1980 and 2013, looking at, and again, not all perfect data. Some of it is observational studies, some of it is retrospective cohorts, some of them are prospective randomized. But the point is, of this chart of 25 studies, only one of them shows an increased risk of local or contralateral tumor, but no increased risk of metastasis or death. Every other 24 out of the 25 studies shows either reduced recurrence, reduced mortality, both, or no difference. So to categorically deny women access when we've got actual published peer-reviewed literature is just an unreasonable and unfair thing. And then you go one step further, there's been 20 published meta-analysis and reviews of those studies, and none of those reviews show any difference. And it's on the basis of the one study, the habits trial, that was published in the oncology literature that scared everybody. And of note, it came out around the same time as the WHI. So it was a poison pill from the beginning. And that own habits trial has a lot of problems with it as well, as do all studies, right? But in life, we've got to take the preponderance of evidence and all the data and individualize it for a patient. And so I review this data with them, and then we make a decision together. And I have an informed consent, so they can sign a consent form. So in terms of any medical liability, because in the US, it's like it's no joke. The medical malpractice is no joke here. And I think that's a very reasonable approach. And as part of the discussion, we also talk about non-hormonal options, and we talk about the vaginal health and the sexual health options, which are not systemic hormones. So
Yeah.
that's kind of how I tackle it.
Yeah, wow. I wish that I had had an OBGYN like you years ago. And, I really do hope that we can come to a point in Australia where we are seeing more informed consent, discussions between clinicians and patients, particularly in this breast cancer survivor space, because it is so important and it is so needed.
And the only way you'll ever get that is it's going to be grassroots, and it has to come from the breast cancer community. So if you care about this, you need to go and tell your oncologist, your OB/GYNs, you have to document, you have to tell them, you have to speak up and say, it's more than just hot flashes. This is what I'm worried about. This is what I'm reading. And it's going to take a lot of noise. But But I think, I think this is the positive side of social media, is that we can all talk and connect over this. And, and certainly for your listeners, I will provide some links and some documents and some, access to things so that they can read and help start to get themselves educated.
That'd be amazing. Thank you so much. And I'll make sure that all of that gets linked through to in the show notes of today's podcast as well. Anybody can reach out to me personally to get those if they're more interested in deep diving into all of that. Corinne, I have gained so much from our conversation. I've learned a lot. I'm pretty sure our listeners definitely would have learned a lot. Is there anything else that you'd like to leave anyone with before we kind of wrap things up?
I would just say, please take seriously menopause. It's not a joke. When it's premature, whether it's at the natural age, there are repercussions, not only to whether you're taking hormones or not, but for other things: bone density, heart health, mental health, sexual health. You're worth it. You deserve it. Pushing at the answers. And I promise you, there is help for you. And the very last thing I will say is, please use vaginal estrogen for life.
Yes.
It's safe for all you breast cancer survivors. That's really low hanging fruit.
It is. Corinne, thank you so much for your time today. I hope that perhaps someday in the future we might see you down here in Australia to speak on this. I think that would be an amazing opportunity for people to learn from you.
Oh, I would love to. That sounds like fun.
We will talk. Awesome. Thanks, Corinne.